So thank you everybody to be with us. This is the first Degos disease workshop, but the first French Degos disease workshop in English, because actually the first disease workshop was in Berlin in 2005, 21 years ago. So it's a lot. And I'm happy to share with you the agenda of the meeting quickly. Partager here. Normally you can see now the agenda of the meeting. We start with the physiopathological aspect, and thereafter clinical aspects, therapeutic approaches. After that, at 4 o'clock, we will have Christos Zouboulis for atrophic papulosis in children and adolescents. After we'll have the 2 clinical cases. We'll have the disease-Degos, Degos Disease Foundation. Thereafter, the 2 clinical cases, and we will finish with a very, very impressive patient testimony. This is the first French Degos disease workshop with a partnership of 2 rare disease networks in France, la filière FI2R for systemic autoimmune diseases and the filière FIMARAD for rare cutaneous diseases, and Claire BODEMER is the head of FIMARAD. And I'm very happy to share this agenda with you, and also with a partnership with Arnaud HOT and Axel VILLANI. And we have built this agenda all together. So we will start now directly with the physiopathological aspect. I give the hand to Emmanuel Ledoux to introduce Axel. So, hi.
Okay. Welcome everyone. Welcome to this first session. So my name is Emmanuel Ledoux. I work at the Department of Internal Medicine and Clinical Immunology in the University Hospital Center of Lille in France. And today it's my pleasure to introduce Axel VILLANI, dermatologist at the University Hospital Center of Lyon, France. So Professor Axel VILLANI will share with us their insights about pathogenesis of malignant atrophic papulosis. And I have to say but I think everyone are very much looking forward to this lecture. So please, Professor VILLANI, go ahead.
Thank you for this kind introduction, Emmanuel, and thanks for inviting me to this talk. So we're going to talk about Degos disease pathogenesis, both the malignant and the benign form, and what is currently, it's difficult to say demonstrated, but at least what is suspected in terms of pathogenesis. And as the title says, it is considered right now as a type 1 interferon-mediated endotheliopathy. It's important because later in this workshop, we will discuss a lot about the treatments that we can try in this very, very severe with very bad prognosis disease. So when you start to look at the literature and you look at the biggest paper with more than 100 patients that are reported, and you start to look at the abstract and what is listed for this disease was basically what's here. It says unknown pathogenesis, mostly described by case reports. So it's complicated. It's very rare disease. You have very few patients. You have not a lot of testing on this, but still we can uncover some details and we can suspect some mechanisms about the disease. First, what is it? Well, Degos is considered to be a primary obliterative microangiopathy. Just a sec, I have a problem with yeah, it's working. Okay, so it's a rare thrombo-obliterative vasculopathy. You have on the top left corner one of the very specific skin lesions. It's important to notice. So you have a porcelain center with a lilac purpuric ring, which is supposed to be a bit specific. And why do you have that? You have the cutaneous form versus the malignant. We said the malignant involves the gut and the CNS, the central nervous system. And the histology is described basically as a wedge-shaped dermal and epidermal necrosis. You can see here in the center the histology, which is extracted by one of the papers by Professor Willis. You have very wide but very well marked dermal necrosis, and on top of that, the epidermis that is also necrotic. And if you zoom into, you can see the vessels that are affected. Here you have the small and medium-sized arteries here in the skin. You have thickened wall of these vessels. You see that the endothelial cells are like thickened and they are progressively sloping into the lumen, and in the end of that, you have some kind of thrombosis that is finishing, let's say, the work and the histology shape of this disease. There is an absence of classical necrotizing vasculitis. It's primarily the endothelial cells that seem to be affected. So what was the first hypothesis? It was like more than 10 years ago, one paper, and basically they suspected a complement-mediated endotheliopathy. So we already said that you had severe endothelium lesions. There were, you can see here, it's one of the pictures on the top right corner also. You can see really the thickened endothelial cells that are sloping into the lumen. It results in fibromucinous obliterative arthropathy. And they did some staining, and you can observe some extensive deposition of the C5b9 complex within the affected vessels. They tested that in skin samples, bowel samples, brain samples in the different patients. So it's diffuse, but it's not limited to thrombosed vessels. So you also have on the nearby vessels that are still not subject to thrombosis, which suggests a primary cytotoxic role of the complement, and then the thrombosis would then finish the work. So it was at this step of the literature considered as a complement-mediated cytotoxicity, but that does not explain why the endothelium is the primary target. Other mechanisms, other suspected pathogenic models were suspected, described. These are very old papers. For some of them, they were listed without very well understanding what was behind that. Some said it was an autoimmune process, a primary coagulopathy, allergic vasculitis, maybe a viral infection. We'll come back to that at some point. Endothelial lipid metabolism, why not? But genetic factors seem to be a bit more interesting. And you have some reports. There is one in the British Journal of Dermatology dating from 1969, 2 cases occurring in the same family. 6 cases here of malignant atrophic papulosis in one family, and another last one with familial malignant atrophic papulosis, which is very strange because you have a very rare disease occurring in one family. Of course, you suspect something behind it, some kind of mutation that would trigger the disease. And you have this recent paper in the Lancet Neurology 2022, and it described the case of a 9-year-old girl with malignant atrophic papulosis with central nervous system involvement mostly. It was not like acute. It was chronic. It was already going on for months, and she was tested, and they uncovered a mutation, which was a heterozygous de novo IFNA1 nonsense mutation, and basically the IFNA1 protein was truncated, and it was acting as a gain-of-function driver of type 1 interferon signaling. The patient had a marked type 1 interferon signature. As you can see here, on the top right corner. It's the interferon score. And she was here, that's her age. So you have 9 years old and you have a very elevated interferon score. And she had an increased proportion of circulating monocytes that were positive for the CD169, which is a population that you usually detect at increased levels when you have a type 1 interferon response in the blood. And she was treated with JAK inhibitor. Here it was baricitinib. That was started merely right after the first interferon score. And you can see the interferon score that is progressively reduced. And then a bit of a flare, and she was treated in the end with anifrolumab. And she had a really reduced interferon score that was mirrored with what is called in the paper as pathological values, but basically you had a clinical improvement that was associated with this treatment. So this is one very important paper in this disease, even if it's only one case, because it uncovers one mutation that here links interferon signaling as the primary phenomenon that then triggers the different endotheliopathy, vascular problems, and thrombosis in these patients. So you had a type 1 interferon signature in Degos lesions. It was already also described in one histopathologic paper, older than this one. They also did some kind of staining. Here, MXA staining, you know, the type 1 interferon-inducible proteins, and it was more present in the endothelial cells, in the inflammatory cells, the epidermal keratinocytes. And when you compare, we spoke about the complement, the C5b9 deposition. When you compare the different stainings between the MXA expression and the C5b9, it was spatially consistent, it was morally paralleled. So it suggests, does not demonstrate, but at least it suggests a mechanistic leakage between the type 1 interferon reaction and the C5b9 cytotoxic reaction. They also did some kind of electron microscopy. They observed some tubular reticular inclusions in the endothelial cells, which is considered as a hallmark of type 1 interferon exposure. It all goes in the same direction. But PBMCs in this patient were associated with a high type 1 interferon gene signature, which was comparable to active systemic lupus erythematosus. And we spoke about the viral hypothesis in these patients. In this paper, they observed cultured and observed viral RNA. The parvovirus B19 was detected in the endothelial cells in several cases, suggesting a possible trigger, but it's not a proven cause. So in this model, the interferon, the type 1 interferon, precedes complement cytotoxicity. Another paper recent, it's not about Degos, but it's some kind of experimental validation in this model, which could be called interferon-driven vasculopathy or interferon-driven endotheliopathy. You have the endothelial cells. They express very high levels of interferon receptor, if not 1 and 2. That's their evolution process. They are early warning sensors for viral infections. So you need to have that to defend yourself against the different viral aggressions, for example. In case of controlled limited interferon exposure, you increase your adhesion molecules, the ACAM1, the VCAM1, the CXCL10, the MHC class 1 to recruit CD8 positive T cells to go in your infected tissues to go against the viral infections and the infected tissues. In case of an uncontrolled chronic or massive interferon exposure, you end up in your endothelial cells with structural damage, hypertrophy of the endothelial cells, and then thrombosis microaneurysm. The endothelial cells are very sensitive. They're primary targets in case of interferon alpha signature, in case of danger signal. And here in this paper, they used a transgenic mouse model with a astrocyte-specific overexpression of interferon alpha interferon. In this model, it was restricted to the central nervous system. type 1 interferon exposure, and it induces an interferon-induced vasculopathy in the mice. And when you associate that with a specific deletion of the IFNA1 in endothelial cells of the mice, it results in no vasculopathy. So basically, suppressing the IFNA1 receptor in the endothelial cells of this mouse model results in no vasculopathy at all. So if you suppress the type 1 interferon signaling, you end up with no vascular lesions in this model. And then they made some parallel with the Aicardi-Gouttière syndrome, of course, which was very interesting. So, but this, because it's a mouse, it's, of course, you can have the whole mechanism and you can suspect that type of mechanism in Degos disease. So it would be a type 1 interferon-mediated endotheliopathy, interferon alpha overproduction, or maybe not overproduction, but chronic production will activate the IFNA1 receptors at this, in the endothelial cells, and you end up with a vasculopathy because you don't have in these patients some kind of negative retrocontrol. It's perfectly explained in the patients where some kind of mutation is described, notably the 9 years old girl with the IFNA1 mutation, but probably you have some patient without the same type of mutations. So, of course, you can ask yourself the question, is sting a potential upstream trigger of this interferon reaction? This is a paper about SAVI patient, stingopathy, interferon-driven vasculopathy with sting mutations. And if you look at some skin clinical lesions, of course, you can, at least if you want to believe that it looks like a Degos disease, it's not exactly the same, of course, but you have some kind of similar skin lesions. So of course, you can ask yourself, is it the same mechanism? It would be a similar downstream phenotype, and it could act as an upstream interferon trigger, of course, but you have no sting involvement demonstrated in Degos so far. The IFNA signaling would be the final common pathway if this is the case in Degos. But we do have some other models that you can think about them, and the COVID childblains, which can be considered as a regulated interferon vasculopathy. I thought it was interesting to compare it to what we just described and cover with the Degos disease. So basically, that was at the beginning of the COVID pandemic, and you had some children with childblains, and they were in the context of COVID, severe COVID infections, not for them, but usually for the patients in their family, but they had basically no symptoms. You had high interferon alpha levels in COVID childblains that were demonstrated. It was limited localized endothelial activation, and it was clinically considered as a marker of viral resistance, maybe because you had high interferon alpha levels in the context of the COVID infection. But you had no chronic thrombosis, and contrast with chronic dysregulated interferon signaling that we just described in Degos disease. So this is limited and controlled without the same severity. The target tissue is a bit the same. It's the terminal microcirculation. It's diffused in Degos disease with the skin, GI, CNS, and it's mostly acral in COVID childblains. The upstream driver would be the interferon alpha, transient and protective in the childblains, but chronic and deleterious in Degos. The complement activation and endothelial injury is more or less the same, but you have no C5 benign described in the COVID childblains, and you have this huge staining, huge presence of C5 benign in Degos disease, which is considered, which is suspected as an endothelial cytotoxicity mechanism in Degos disease. So these childblains could reflect partial upstream complement activation, whereas in Degos disease, it engages the terminal complement pathway with irreversible endothelial damage. And the thrombosis, you have very few in COVID childblains. Sometimes they are associated with elevated D-dimers, but you have frequent intraluminal thrombosis in Degos disease, also highlighting that the mechanism is way more severe and not regulated at all. So the thrombosis would then, in this model, be a downstream effect of the endothelial activation, and it's not a primary coagulation disorder. So it's not entirely unknown, as we said in introduction, for this Degos disease. After all, it would be then, at least for what we have in the literature, an interferon alpha-mediated vasculopathy with severe thrombosis due to C5b9 toxicity. Some genetic factors are well described, very well described in some case reports, and notably IFNA1 related mutations. It's a concept of type 1 interferon-mediated endotheliopathy. You can observe that, of course, in the Aicardi-Gouttière, the systemic lupus erythematosus, the COVID-19, as we just discussed, and the Degos disease. It has also, we discussed of the viral trigger that was described, the parvovirus bedizimab, but if you think about the COVID-19, could also be some kind of viral trigger. You have the same global pathophysiological axis with the interferon alpha, the IFNA1, the endothelial cells, and the vasculopathy, but you have it being acute and regulated with no systemic damage in COVID-19, and acute chronic. It's not really acute, it's more chronic, and then brutally, it's not regulated anymore, and you have some kind of very acute clinical symptoms in Degos disease with permanent tissue damage. And probably with that in mind, targeting type 1 interferons as fast as possible could be of vital importance in such vasculopathies, and notably Degos disease. So thank you for your attention. And it was, I did not take the whole time for the lecture, so we have time to discuss.
Thank you so much for this clear and very insightful lecture. So so the discussion is open, so everyone can, if you want to ask a question, submit it in the chat, and if you want to ask your question verbally, please just say so in the chat, because we have to change your statue.
I think Christine has a question. Hello, Christine. Christine, you're mute.
Sorry. Hello, everyone. It was a very nice lecture. Thank you very much, Axel, for that. I just have a comment. In children, in my experience, even if it's very rare, I have observed pseudo-Degos in patients with dermatomyositis. And it means it's another example in children of novel interferonopathy type 1. And so I really think that this pathway is very, very important, as you have well described that, with the importance of the anti-JAK treatment, sure. And did you have, in your experience, such manifestation in adult patients? It means dermatomyositis with the development of pseudo. It is called like that. I don't know if it's the best word to use, but pseudo-Degos.
I don't have personally that in my experience, but we can ask the panel that is who is present today. If you,
yeah, okay.
Why would it be observed only in children and not in adults? I don't have a.
I haven't seen never in adults such presentation so far.
I really think that in children we can say that dermatomyositis are interferonopathies, and it's probably not exactly the same in adults. I don't know, but the role of interferon type 1 is very important. So we have a lot of comments.
Yeah.
Yes.
Please, Professor Zoboulos.
Yes, again, from the side of a dermatologist, if you see the classical lesions who are indeed pathognomonic, it never happened to me, to a patient, to find that he has a pseudo atrophic papulosis. So the patients have the disease either as cutaneous disease, or they develop later on, or they have already, together with the lesions, the systemic manifestation. So I can say that for me, it's also the typical, no specific, or pseudo-Degos and a known picture.
Thank you. Dr. Boehm?
Yeah, so I would like maybe learn a little bit more about what makes the diagnosis of pseudo-Degos. Are these the similar skin lesions, or are these the gastrointestinal similarities or the neurological findings? Maybe Dr. Sadler can. This was Dr. Sadler who said who asked about the pseudo-Degos.
In pseudo-Degos, in my experience in children, the cutaneous manifestations are typical. The particular aspect of what is observed in Degos disease. It means it's quite different from other vasculitis or other cutaneous manifestation related to thrombosis. Is with this so particular white aspect of the skin, round white aspect of the skin with inflammation around this color and the evolution to necrosis. And in these patients, it's children, only few cases. I don't remember, but no more than 5 cases, and probably 4, something like that. Where I had also have also observed mucosal manifestations, mucosal manifestation in the esophageal manifestations, and with the same aspect, that's the aspect on the skin, with this white color, this inflammation around, and so on.
I think that's very, very interesting. Are these patients NXN2 autoantibody positive?
It was several years ago, and we didn't perform such investigation, unfortunately. And the evolution of these children with very severe dermatomyositis, but with no, at this period, the possibility to have to characterize which antibody was involved in each case. And finally, it was very severe dermatomyositis with the absence of response with steroids at this period, methotrexate, steroids, classical treatments at this period, and with fatal evolution in all these cases. So very severe diseases, which has not been controlled with the use of steroids.
Mm-hmm. So something that we observed in our patients when we look at the mucosa in the esophagus and also in the stomach were very atypical lesions that our gastroenterologists could not put into known lesions. So there might be some similarities between these dermatomyositis and these and the classic Degos patients.
Yes, I agree. I think that you are right.
Do you still have these patients? We can talk later.
We have to thank you,
yeah.
But maybe you can talk by chat. Professor HACHULLA, maybe a comment?
Yeah, maybe we still have 4 minutes because we started at 3:05. So we have 4 minutes to finish the discussion. My question was Axel, so if I have good understand, if now one is dysregulated, so this makes sense to target, if now one with anifrolumab, C5b9 is guilty, so it makes sense to target also C5b9, and we'll see that with Marie-Robert. But the question is, in the family of interferon type 1, we also have the beta interferon. Is there a signal of an increase of beta interferon also, because we now have a drug targeting beta interferon, the dazukibart? What do you think? Would you think this could be relevant in Degos disease?
It's difficult to answer that, but basically with the knowledge and what is currently published is mostly about interferon alpha that is reported. But since you have an elevation of the different type of interferon receptors, you cannot exclude that this mechanism is also, remember that it's like very, very few patients that are described to make this mechanism. So you cannot exclude that this mechanism is the same for all the Degos disease, and that you cannot have some of them that is more linked to the beta.
Thank you. Thank you.
Yeah, I might have one question. Do you there are evidence about the involvement of the type 1 interferon pathway in Degos disease, and you showed evidence of the involvement of the complement pathways, at least. But I'm sure. So do you see the complement pathway as downstream consequence of or an independent driver of the disease?
No, it's considered as it's difficult to make positive sentences with so few data. But in this model, the one I presented, it's the downstream consequence of the type 1 interferon signaling. Basically, you have your endothelial cells that is very sensitive to your type 1 interferon. Its architecture is remodeled because you have two chronic exposure to type 1 interferon, and this activates the complement ultimately up to the C5b9 without any back control, negative retro control to stop this reaction.
Yeah, because there is this model, monogenic model, such thing. So in the other model, there are no events such as strokes, such as gut involvement, microperforations, eye involvements. So that's why I'm not sure. I don't, is this just interferon mediated, or is there more than that? Because if we consider to use combined therapy targeting the both type 1 interferon and complement, and if we induce remission, prolonged, what should we do? Stop, withdraw, stop? So I don't know. So what are you inside about?
That is an excellent question. Eric is saying that the clock
okay.
is there, but it's an excellent question. I asked myself the same. I don't have the answer. Why is it targeting skin, gut, CNS, and why in models that are mimicking this mechanism, it doesn't target exactly the same tissues? I don't have the answer. Maybe you can hypothesize that it's a problem of sensitivity to type 1 interferon. Maybe it's overexpressed in the endothelial cells that are in this specific tissue, and that I don't know. I don't know why in some. And if you have to target, if it's associated with a mutation, the case of the 9-year-old girl, you have to treat them all their life as far as I know. The model is basically a chronic exposure to type 1 interferon and acute symptoms, but the mechanism is not acute, it's considered chronic. So it's like, you can imagine a bridge, the bridge of the lovers, you put the lockers on and it resists until it suddenly breaks down and everything goes shut down.
Thank you so much.
Yeah. Thank you both for the nice discussion. Thank you. We are just on time. I think I haven't seen Arnaud HOT. Marie, can you tell us if Arnaud is there or not?
I don't think so.
No,
but
I contacted him by phone, but no answer. So just Marie, thank you to be there with us. Marie Robert is working, if I know well, between Lyon and Paris, between Hôpital Bichat, Institut Pasteur, and also Lyon. And she has high knowledge about Degos disease and treatment of Degos disease, and she works on the physiopathology too. And now you can present us how to diagnose, how to treat this patient. Thank you, Marie.
So thank you, Prof. HACHULLA. So good afternoon, everyone. I'm Marie Robert. I'm currently resident in internal medicine in Paris, in France. I'm also doing some research in immunology at Institut Pasteur, and I have discovered malignant atrophic papulosis thanks to Arnaud HOT a couple of years ago. And since, let's say, 3 or 4 years, we are working together with the team of Lille and with Prof. Axel VILLANI trying to understand better the pathophysiology of Degos disease. So Axel has presented the pathophysiology. I will try to give you an overview of the clinical aspects and the therapeutic approaches.
We can just see your first slide.
Yeah,
Is
I
that
will
normal?
just, yeah, exactly. Because now I will just give you the outline of the presentation. We'll start with some epidemiology. Axel has already done the pathophysiology. I will give you, as I said, the overview of the clinical manifestation, the diagnostic approach, and the treatment. And we'll speak again about the Degos-like lesions that were discussed during just previously. So just as a reminder, or for the people that don't really know Degos disease, so now we are talking about atrophic papulosis with two forms of the disease. So in 1/3 of the cases where patients have been in atrophic papulosis, and in 2/3 of patients we have malignant form of the disease. Some patients start the disease with cutaneous-limited disease and then develop some systemic involvement. So today I will discuss more about the malignant form of the disease. So it is considered, and I briefly, as a rare obliterating vasculopathy with around 200 cases described so far. In adults, the sex ratio is around 1 with slight predominance of female, and the mean age at diagnosis is 32 years. There are some pediatric cases of malignant atrophic papulosis. I will do a slide on it just after. And so what are the risk factors of the disease? Some variants were described as associated with the disease. One, especially as Axel told you, in the receptor of interferon alpha. It was in a child, and also some viral infection have been associated with the disease, with the parvovirus B19, and in the context of autoimmune disease, some patients also displayed some Degos-like lesions, and so there was quite a long debate about the role of autoantibodies in malignant atrophic papulosis, targeting, for instance, endothelial progenitor cells, but also autoantibodies that were related to, for instance, antiphospholipid syndrome. And the mortality of the disease is very high, with up to 75% of mortality rates when there is either gastrointestinal or neurological involvement. So this is a figure with an overview of the organ that can be affected during malignant atrophic papulosis. And globally, any organ can be affected. So the skin is in almost all patients affected. We will see just after the kind of lesion we can observe in this disease. In adults, then GI involvement is observed in 70% of patients, and followed by CNS involvement in almost half of the patients. But as you can see, any organ can be affected with the eyes, the lungs. Cardiac involvement is also possible, and the kidneys, the spleen, and the muscle. So let's see together the most frequent manifestation observed in malignant atrophic papulosis and in the benign form with the skin lesion that you can see. So here is a typical cutaneous lesion that you can observe in atrophic papulosis with this particular central umbilicated porcelain white center, and then which is surrounded by this erythematous and telangiectatic rim. So you can see here other illustration of the skin lesions, and in adults it's mostly asymptomatic, mostly evident observed in the trunk and the extremities, and the cutaneous involvement is usually the first manifestation of malignant atrophic papulosis in around 2/3 of patients. Usually, those skin lesions precede the development of systemic involvement with a median time from skin lesion to systemic involvement of 2 years. So it's sometimes quite difficult to identify the pathognomonic skin lesion of the Gauss disease because, as you can see, the lesion evolves over time. So here you have an early stage lesion, then the fully developed lesion, which is the most commonly observed. Here it's a dermoscopic examination, and here you have the late stage lesion. So it's not always easy, even if you know that the Gauss disease is associated with a pathognomonic skin lesion. Be careful, because sometimes you can be faced to an early stage lesion or a late stage lesion that are a little bit less specific and easy to identify. So here are other illustration of the skin manifestation occurring during atrophic papulosis. As I said, it's usually located in the trunk, as you can see there, for instance, in a child, and in the extremities, with always this white center and the telangiectatic rim. So here you have different illustration from several case reports. So then the second manifestation that need and must be recognized by a physician, it's when GI involvement occurs. So around 70% of patients develop GI involvement during the course of the disease. So the symptoms are rather non-specific to GI involvement in malignant atrophic papulosis, but really we need to look for them for abdominal pain, cramping, weight loss, vomiting, nausea, and diarrhea. And the kind of lesion you can observe in laparoscopy, for instance, are ischemic lesions, and they can lead to bowel perforation, peritonitis, bleeding. The small intestine is more commonly affected as compared to the other part of the GI tract. And as you can see on this picture, you have this kind of lesions that are also white and correspond to small infarcts. So you have several, again, kind of lesions of the GI tract. You can see that those two pictures are rather similar, but here you have another kind of lesion that can be observed. And one point that I really want to highlight is that in this paper from Toledo and colleagues from 2015, each case of perforation was preceded at least by one gastrointestinal symptoms. So it's really important for physicians to look for these GI symptoms, because, and it's really important to then go for other additional exams and to discuss also with the gastroenterologist, because as I said, symptoms are then can be followed by perforation, and it worsens the prognosis of the disease, because in one of the biggest series of patients, GI bleeding was responsible for 23% of death. So let's see then the CNS involvement in malignant atrophic papulosis, which occurred in almost half of the patients. So there are two kinds of neurological involvement. The most frequent one is the neurovascular form, but there is also some parenchymal lesions that have been described. So the symptoms are related to the ischemic strokes that can be observed. We can also have some cerebral vasculitis that can be seen, and some spinal lesions, and quite non-specific leptomeningeal enhancement. Again, as for GI involvement, CNS involvement, as you can think, it worsen also the prognosis of the disease and explain around 10% of death. So let's see together the different kind of CNS involvement we can observe during malignant atrophic papulosis. So here are some examples of ischemic stroke and a spinal lesion. So it's a patient who first presented some focal lesion, as you can see there and there, but also an abnormal leptomeningeal enhancement within the basal citerns and the sylvian fissures. And 8 days after this first MRI, the patient, you can observe some again, the leptomeningeal enhancement and some new ischemic strokes and also spinal lesions. The other kind of manifestation of CNS involvement in malignant atrophic papulosis include cerebral vasculitis. So here you can observe some images of a 32-year-old woman who display a progressive narrowing of the right-sided cerebral circulation, for instance, as you can see there, and on this exam also near the arrows. So we have seen that some ischemic strokes, spinal lesion, leptomeningeal enhancement, and cerebral vasculitis can occur in malignant atrophic papulosis. And as I said, any organ can be affected during the disease, including the eyes, with also some involvement of oculomotor nerves. You can have some pleural effusion and fibrosis, and also some cardiac involvement with some constrictive pericarditis that have been reported in a paper from Lee Shapiro, for instance. So I just would like to highlight some specificities of pediatric atrophic papulosis, and I won't go too much into detail because Prof. Souboulis probably will talk about his article published 2 years ago. But just to do a little focus on pediatric atrophic papulosis in this series of 19 patients, as opposed to adult, there was a male predominance. And so the median age at onset was 5 years, with a more frequent systemic involvement as compared to the adult, because there was around 80% of patients with malignant atrophic papulosis, and one of them had a family history of MAP. So if we take the same scheme as previously, here in children, you have scheme involvement in all patients, and here it's the CNS involvement, which is more frequent than GI involvement. As you can see, you have also, as compared to the adults, more frequently cardiac involvement. So let's see together and the kind of CNS involvement we can observe. So Axel already mentioned this case report of a young girl who carried variant in the interferon alpha receptor. And interestingly, this little girl display also quite other kind of lesions, and as we have described for the adult. So you have some nodular here and ring enhancing lesions that you can observe here and there. And you have also some hygromas, but also here you see the edema, but in fact there were some calcification. So to my knowledge, in the different case report of malignant atrophic papulosis, calcification were only described in this case report and not in adults. And that's why, as Axel mentioned it before, sometimes we can consider that atrophic papulosis is a kind of interferonopathy. So just quickly, as I have already said, when you compare pediatric and adult form of the disease, the proportion of patients with malignant atrophic papulosis is slightly more elevated in children than in adults, with CNS involvement being more frequent in children. If you looked at the survival of this patient, of course, when there is a systemic involvement, the survival is decreased with around 40% of deaths in children. And if you compare children and adult patients, it seems that the disease is even more complicated to control in children, but Professor Brice will describe it later. So what about the diagnostic approach? So the first one, as I mentioned, is as almost all patients display some skin lesions, a whole skin examination is absolutely needed. With the skin biopsy can also help, even if there is no real pathognomonic signs of Degos disease. You can see some thrombotic microangiopathy, some intraluminal fibrin deposition and thrombus. As Prof. Villani mentioned, you can have also a diffuse C5b9 staining, associated, of course, with an overactivation of the complement pathways. And also, you can observe an MXA staining, which is associated with an activation of the type 1 interferon pathway. So the first part of the diagnostic approach is the whole skin examination and the skin biopsy. So then, as I said, the time between the development of the skin lesions and the systemic form of the disease is around 2 years. So the physicians really need to look for gastrointestinal symptoms, and in this case, urgent laparoscopy is required. At diagnosis also, we must look for neurological symptoms, and probably the brain MRI is more sensible than the CT scan. And then some routine tests. The complement level measurement can be interesting. A screening for autoimmunity and infections is also important because, as I mentioned, and malignant atrophic papulosis is a very rare disease, and we must look for other kind of autoimmune or infectious disease, and probably the interferon score could be interesting, and Dr. Emmanuel Ledoux will describe a little bit later a case report in which they follow the patient in addition to the clinic on this interferon score. And then the coagulation test or thrombophilia testing has been suggested in the past, but as Axel said, it's not Degos disease is not really coagulopathy. So what are the differential diagnoses of Degos disease? So you were discussing a little bit earlier about Degos-like skin lesions that can be observed both in children and in adults. There are probably more manifestations of a small vessel vasculopathy. And as you can see, and you may know that 2 years ago, there was this paper in JAMA Dermatology focusing on patients with systemic sclerosis who also display some Degos-like skin lesions, as you can see on these pictures with these white porcelain centers. So they reported that around 5% of systemic sclerosis patients have Degos-like skin lesions. They are most commonly located at the fingers, and when they compare the systemic sclerosis patients with and without Degos-like skin lesions, they identify some association with acrosteolysis, ulcers, and calcinosis, and the patients had more frequently diffuse systemic sclerosis. So then in some lupus patients, some Degos-like lesions were also identified, as you can see on this picture, but then the screening for autoimmunity helped the physician to finally make the diagnosis of systemic lupus erythematosus. And here it was a case report about a patient with a discoid lupus who also display, it's true, some Degos-like skin lesions, but then the histopathological findings were in favor of lupus. you were talking about dermatomyositis, and there are also some case reports showing some patients with Degos-like skin lesion, as you can see on the different pictures. And there was a case report, like in August, I think, in rheumatology, in which 2 patients with NXP2 dermatomyositis also display some Degos-like skin lesion. But of course, there was other clinical manifestations and biological findings that allow the diagnosis of dermatomyositis instead of atrophic papulosis. So what about the therapeutic approaches that are used in malignant atrophic papulosis? So really, so far, the treatment is empirical and based on what we know about MAP pathophysiopathology. So as Axel mentioned, there is probably a part of endotheliopathy mediated by the complement pathway overactivation and interferon pathway overactivation. And so the treatment that are currently used in MAP patients are targeting more or less these 3 pathways. So from this study, we can first learn that monotherapies are not it's not enough to use monotherapies in malignant atrophic papulosis, including for antiplatelet, for instance, as you can see that 40% of patients showed no improvement under antiplatelet. Steroids are not efficient in malignant atrophic papulosis, and so probably, based on this data, in malignant atrophic papulosis, which is a very severe disease, combined therapies should be probably, well, seems to be superior to monotherapies. So what about eculizumab? As you know, it's an inhibitor of C5b9. This treatment was firstly used in malignant atrophic papulosis with GI involvement. And in addition to the clinical improvement of the patient, you can see on this biopsies that before the treatment, of course, there was an intense staining of C5b9, which disappeared under eculizumab. The problem with eculizumab is that it's not always effective. It takes a lot of time to remove the C5b9 deposit, around 5 months. It fails also to prevent chronic vascular damage and to prevent also gastrointestinal relapse. So that's why, again, we, based on the data that are available, we believe that combined therapies are probably indicated in a patient with malignant atrophic papulosis. And in addition, from other series of patients with systemic manifestation, including CNS, cardiac, or ocular involvement, eculizumab seems not effective on this manifestation. So these are some limitations of using eculizumab as a monotherapy. So we can wonder why eculizumab may be inefficient in some patients. And as you can see, here you have a skin biopsy before the initiation of the treatment with the intense C5b9 staining. And here you have the MXA staining. And I remind you that it's associated with an overactivation of the interferon pathways. And interestingly, after eculizumab, you have clearance and rather negative C5b9 staining, but there is still an intense MXA staining, meaning that there is a persistent activation of the interferon pathway at the tissue level, despite eculizumab, which targets the complement pathway. So Emmanuel Ledoux will describe and will present later this case report, but again, it's another illustration showing that eculizumab is sometimes not enough to prevent worsening of the disease, and with Prof. Eric HACHULLA, they identified that despite the blockade of the complement pathway with eculizumab, there was still a very high blood interferon score, meaning that there is a systemic overactivation of the interferon pathway despite eculizumab. So, considering the data I have described and all the case reports available on a patient with malignant atrophic papulosis, we believe that combined therapies must be considered in these very severe patients. It has been suggested when there is only, if I can say that, a GI involvement, that the association of eculizumab with treprostinil may be superior to eculizumab alone to prevent a gastrointestinal relapse. Based on 2 case reports on what we know about the pathophysiology of the disease and the inefficacy of eculizumab on non-GI systemic manifestation, we could propose, and I want to be very cautious about this statement, to use a combined therapy, including eculizumab in association to interferon pathway inhibitors, as well as aspirin. And as you can, and all of you are aware of the side effect of this treatment, but when you associate eculizumab with interferon pathway inhibitors, you really need to think about the prophylactic measures to prevent infections. So here are the key messages of this presentation. First, systemic involvement can occur years after initial skin manifestation. The median time is around 2 years, but it can also happen more than 10 years after the initial skin lesion, and any organ can be affected in the disease. The second key message is that when you have gastrointestinal symptoms in atrophic papulosis, urgent laparoscopy is absolutely required and treatment. So when we talked about treatment, we talked about combined therapy, and it's really a proposal of off-label rescue therapy, including eculizumab and inhibitors of the interferon pathways. It could be, for instance, anifrolumab and JAK inhibitors and low-dose antiplatelet. Third, when you have a MAP patient without GI involvement, as eculizumab is not efficient on non-GI manifestation, interferon inhibitors are really interesting, and there is an ongoing clinical trial driven by the NIH to treat CNS involvement with baricitinib, JAK inhibitors. And fourth, as it's a very rare and severe disease, we believe that it's very important to discuss these patients with either the Degos quarter limiting members, or in France with, for instance, the centers of Lyon and Lille, because it's very difficult. Like the management of this patient is absolutely and very difficult, and must be discussed with different specialties and different physicians. So on that, I would like to thank you for your attention, and we have some time for discussion. So don't forget that I'm only resident, so I will be very glad to discuss this presentation with you and with the other experts that are connected. Thank you.
Thank you, Marie, for that presentation and the nice overview of the clinical aspects and therapeutic aspects. Because we have a tight schedule, what I propose is to give the hand to Axel VILLANI to present Christos Zoboulis to resume the presentation of the clinical aspects of the disease, and we will discuss both presentations just after. Axel.
Thank you, Eric. So it's my great pleasure to introduce Professor Zoboulis. He's the head of the Department of Dermatology in Dessau. He's internationally renowned for his major contributions, notably to hidradenitis suppurativa research. He's one of the founders of the European Hidradenitis Suppurativa Foundation, within which I have the great pleasure of working alongside him. And he has an exceptionally prolific scientific output, and this is why we have him today, is the author of numerous landmark publications on Degos disease. Please, Christos, the floor is yours.
Thank you so much for the kind introduction. Happy New Year to everybody, and the best greetings from the frozen Germany. We experienced just now the warming, on the contrary, of the environment. We are at -9, expecting -17 in the next days. So thank you so much for giving me the possibility to present on a disease that together with Dr. Shapiro involves me since many, many years, and has led many studies first to be successful, sometimes not. The disease has a nomen, it's clear, but has a lot of synonyms, as you can see. So there are several names defining. This is not something rare for rare diseases. They have different names because many colleagues have given different names as being confronted with this extremely rare disease. If we look in the literature where we are, we see exactly what is going on. Very few publications. There is an increase since 2001, but as we see every 10 years, 118 expected publications until 2030. It's not much. The first conference, as Professor HACHULLA said, it was in Berlin, indeed, with patients from all over the world at that time, where we collected samples and documentation. It was the basis of our work in the year 2005 and further on. And then we went to the United States in 2011 to have the first American meeting. Going to 2016, again America, 2 to 1 to Europe. And this is why I'm very happy that we are now 3 to 1, as you see, with malignant Atrophic Papulosis in NIH. But through the French colleagues, we come back to Europe today, which is a very important thing if we consider that we need more information on the disease. As already said by the colleagues before, we have two types of the disease. So I prefer to call the disease Atrophic Papulosis as a general. And we have the benign form and the systemic form with the manifestation almost in every organ. Dr. Robert presented very well the clinical manifestations and the skin manifestations, but I would like to give you some more information a little bit on the development of the lesions of the skin. As you can here see, we have an early lesion, which is a little papule, mostly skin colored, going to the fully developed lesion with the peripheral widening of the vessels, going to the so-called scar at the late with the reduction of the erythema. We consider since many, many years that this late stage is a scar. Let's see how things develop. Again, we see the time dependence, which is very quick from day 1 to day 4, as of from the initial lesion to the so-called scarring lesion. And we see also, thanks to the work of Dr. Robert, Professor HOT, the development of the lesions with changes on the epithelium, necrotic changes of the keratinocytes, and involvement especially of lymphocytes. But the reality is, if we look at all these different pictures, which is polymorphic, so we have different flares of the disease, increasing the lesions at different places. They are not monomorphic on the first side, but if we look at them again, they are actually monomorphic with the different stages. But the most important thing is that we have here something that symbolizes lupus erythematosus. So we have a lot of mucin deposition around the scarring lesion. And I say scarring always in brackets because in the reality is that the scarring lesion is not scarring. There is some scar, but it's an active lesion. So the wedge-shaped skin necrosis that we think it's a scar, it is still active over years. And you can see here the comparison we have made, early lesions and very late lesions, years later on, and you see in the histology further the involvement of the vessels. So the so-called scars are not scars, and this is the reason why they can resolve. Here we see a patient that I have followed over 30 years, and you see how she resolved over these years. So even the scars, when you expect that they will stay like they are, they resolve because they are not scars, because they are active lesions over the years through. Now, if we look at the clinical manifestations, it's already said, so I don't need to repeat the things, but what I would like to show is the second box down in the familial occurrence, systemic manifestation in familial disease, and systemic manifestations in spontaneous disease. And we see that the systemic manifestation in familial and spontaneous disease in all different studies being made are very similar. So the reality is we have a familial occurrence, which is not very common, and we have systemic manifestations, however, in both the spontaneous and the familial disease. In the last work we have done with the 105 patients that we have seen initially in Berlin and later on in Dessau, we see that we have, in addition to the skin, which is 100% presentation, we have 38% of the patients with gastrointestinal involvement, and 38% with CNS, and interestingly, the third systemic manifestation seems to be the ocular involvement, followed more early by heart changes. Dr. Robert presented very well the clinical manifestations. I will say only in one, and this is the very typical avascular scar of the sclera in the eye. So if you see this lesion and you have some lesions in the skin, are very typical for Kohlmeier-Degos disease. And we have also kidney involvement, vascular kidney involvement, which can be acute, leading to neurocatharsis. Which other organs, heart, eye, and lungs, bladder, liver, and pancreas have been described. About the pathogenesis we have discussed, it seems to be an interineuronopathy, so I don't need to lose more time on that. There are already mutations described. And we try to see the genetic background in our patients, and actually we did not come to a final result. As you can see here, only in one family, the family 03, was some kind of genetic background in 2 generations. All the other families, we could not find any genetic background. We also try to find in patients with cutaneous involvement only if there is some markers that couldn't be used. What we found is only increase of interleukin 8 in the patient serum and the reduction of vascular endothelial growth factor and cardiolipin antibodies, which has increased. So nothing else. So taking all this evidence, we can classify at least the vascular disease of the skin to the non-antineutrophilic cytoplasmic antibody immune complex vasculitis of small vessels, according to the Chapel-Hill classification. In our study with 105 patients, we had an equal male to female ratio, maybe a little bit more women, but does not make the big difference. The patients are between 20 and 50 years with a male mean age of 29 years, a later mean age of females with 37. Again, no very often familial occurrence, 8%, systemic signs in 40% of our patients, and a mortality rate of 19%. Comparing the benign and the malignant disease, the only difference we see is the mortality. We don't have any dead patients among the patients with benign atrophic papulosis, while we have a considerable number of patients who have seen with the systemic disease. Now going to see with a new study, the previous study spoke about 7 years follow-up. Now looking at what is the probability of survival in the malignant atrophic papulosis. We have now evaluated the 13-year probability, and with a long-term follow-up of about half of the patient. So if a patient has 13 years of benign disease or malignant disease, then the probability to die is minimum. The mortality rate was 22.6 in the malignant papulosis, and the major role of death is the involvement of the central nervous system. Again, here, if we go to the children group, which is a number of 19 compared to 77 adults, we have some differences. The rate of benign to malignant papulosis is significantly more common in the adults. So the children have more systemic disease. And there are also differences in the CNS involvement, the gastrointestinal involvement, and the cardiac involvement, which are more common in children. If we look about the ages of the pediatric patients, it's very peculiar that the majority of the children are involved until the age of 6. And there are also some children with the entering of the puberty, but the majority indeed are until the age of 6, and then most patients are until the first year of life. Looking from the PubMed, the clear and secure data with case reports, we came out with 43 case reports until the year 2025. Among them, it's equal male to female, 1.15 male to 1 female. It seems that the children male are more common than female. As we said, in the adults is female with 1.6 to 6 something more, but I would say actually 1 to 1. And regarding the manifestations with skin involved in 100% of the cases in these children, 65% CNS, 51% gastrointestinal, 14% eyes. As you see, eyes are very important, and I know that very few colleagues send the patients to a very good clinical examination of the eye. We have to do it because it's the third organ after the two important organs. And then from the patients presenting case reports, 58% of the patients died. Again, the comparison of survival, it's much better in the adults than in the children. And if we look at the multivariate analysis, what are the most important reasons of worse prediction of survival are the CNS involvement, also in the multivariate as in the univariate, the gastrointestinal involvement in the univariate but not in the multivariate, and any organ in comparison to no organ as a comparison to only skin is very clear that this is the case. So the pediatric atrophic papulosis have some distinct features in comparison to the adult group. There are more males than females in comparison to the adults. There were some more females than males, but again, does not make the big difference. And the systemic involvement is particularly gastrointestinal, central nervous system, and the cardiac, which are more frequent. But now we see in the cases also of the literature that the eye involvement is also important. So we say there are 4 organs, 2 very common: central nervous system, which is very important also for the survival, and gastrointestinal, and then the next group, equally cardiac and eye disease. And I finish with the diagnostic plan as we have proposed already the year 2014, an annual follow-up for the first 7 years of the disease and then biannually thereafter. Essential diagnostic tools is a whole skin examination, skin body biopsy for histological examination, which is not absolutely required. It is essential to give the final picture, but if you are experiencing to see the lesions in the skin, it's very classical lesions that you cannot miss the diagnosis by that. Fecal occult blood test to see if there is some blood already problems with the gastrointestinal tract. However, again, laparoscopy is clearly more diagnostic in the early stages, and ocular examination. And to the other side, as I said, colonoscopy, gastroscopy, they are not as good as laparoscopy. We need laparoscopy for the early stage manifestation, brain magnetic resonance imaging with contrast, head ultrasonography, thorax computed tomography with contrast, and kidney function test. The problem that we have been confronted, in Germany at least, is that pediatricians do not want to make laparoscopy. So we have to try many times, and we're not successful at every time. They prefer to make a gastroscopy or colonoscopy, and they avoid laparoscopy. And by that, I hope that I could save some time and give you the information on the data that are existing, plus the pediatric data that we have at the moment in our hands. Thank you very much.
Thank you so much, Christos, for this presentation and the lecture. I'm sure we'll have a lot of questions because we can ask questions about the last two lectures. I don't have I can take a look at the chat, but else I have a few questions for myself. First, I think that the last thing you discussed about the systematic follow-up about these patients is essential, because I have in mind one patient that we'll discuss later that was just examined, and she did not have some systematic testing. And once we performed these, we uncovered that she had very slight lesions in the central nervous system, and she was requalified in progressively going to the malignant form instead of the benign. And if you just look at the skin, it's very important. You can falsely reassure you, basically. So do you have other cases like that in mind, Christos?
Yes, several cases, not only one, where we have been not satisfied by the fact all the skin lesions, and we make the test. This is why they send the patients to us at least. And we find changes. At the moment, it's very interesting that we see almost exclusively children. At the beginning, when we started in the beginning of the century, we had a lot of adults. And we also found 2 patients with very severe eye disease. And this is the interesting story. We are experienced with Adamantiadis Behçet's disease, and we know that there is a peripheral vasculopathy. And we see the same story also with the eye now, that the patients see, despite the lesions they have at the periphery, where they have occluded vessels. So we need to make the fundus examination and also the examination of the sclera. And we had 2 adult patients that they were progressive only in the eye, in addition to skin. By the children, unfortunately, when the children come to us, they have systemic disease.
We have one question, Dr. Yeah,
Christos, excellent presentation. I have a question and looking for your advice. So we usually classified the skin lesions, if there is no other organ involvement, as benign, and any other organ involvement as malignant. Do you think there could be, or what are your thoughts on other organ system involvement that does not progress to a malignant form? Because for the patients, it's quite traumatic to hear from us, oh, it's systemic, or we found it in another organ, it's systemic, and all these complications and progressions that are associated with.
My friend, thank you very much for this very important question. Be sure that it's also a problem for me. What I can say at the very moment is that we have to say 100% sure that gastrointestinal and CNS involvement and peripheral and neurological involvement, which is now more and more common as I see, they are systemic. For sure, there is no discussion that heart involvement, vessel involvement, and kidney involvement, which is acute involvement with kidney insufficiency very quickly, especially in children, are systemic. What it makes me a little bit careful is the liver involvement, which is not so problematic as I have seen in our patients in the literature. And the one involvement that it makes me in difficulties to decide is the eye involvement. The combination of skin and eye, I still very carefully say it could be considered as benign.
Thank you.
Professor HACHULLA?
It's a question in the chat actually for Christos, but also for Marie. For GI involvement, does endoscopy help with diagnosis, or must it be laparoscopy?
I leave it to Maria first to answer.
Marie, can you take the question?
Are you still there with us?
I think she sent me
no, she Marie is not present.
Yeah, she's still in the department, and I think I have to. She had to go see a patient. That was one of the texts. I'm sorry for her.
I have learned from Lisa Piero. I mean, with his excellent work in this field, I'm 100%, as I have learned from him, that laparoscopy is absolutely required. Because as far as you have perforation, you can see it also with gastroscopy. It's too late. And I had this case, very, very sad case with a patient here in Germany. I don't say which hospital. I was asked to participate at the council. I very strongly asked for laparoscopy. They denied laparoscopy, and in 1 week later, the patient had already perforation. So they decided to make the treatment after the perforation. So I'm very sure that laparoscopy is required if you want to recognize the involvement early enough to have successful treatment before perforation occurs.
I have another question, Axel, for Christos. So there are two kinds of disease: benign form, cutaneous form, and the systemic form. Are there some prognostic factors that you can identify, some biomarkers that you can identify in the benign form, predicting that in several months, 1 year, 2 years, this will evolve to a malignant form? Yes or no?
Eric, at the moment, no. The only predictive factor is time. If a patient goes over the 2 years, the first step is 2 years, because the majority of the systemic diseases occur into 2 years after the manifestation of the skin lesion. If they pass over the 2 years, that's a good sign. If they go over 7 years, it's 67% probability. If they go over 13 years, it's 99% probability. So these are the points. And when I speak about probability, I speak about non-development of systemic disease. But interestingly, also if they pass over 13 years and they have systemic disease, the systemic disease does not progress. So the two first steps is for benign, 2 and 7, and for 13 is survival.
And you think the interferon signature, for example, could be a biomarker predicting something, or?
I'm biased because, you know, I have been involved in this case that we have treated with anifrolumab. Yeah. We try now a second case. I have asked myself if I would like to make a clinical study, a pilot clinical study with 10 patients with systemic disease for 2 years with anifrolumab, just to have a sign. The problem is that you know much better, in Europe, the administration of making multi-center studies over the borders of one country are so huge that they don't dare up to now to start this procedure. But I think that if we manage in a way to have a European Union supported clinical study, I would be very strong of proposing and promoting the idea of interferon inhibitors to treat. Of course, we have with Manfred a little bit their different opinions, which interferon is the important one. But at the end of the day, I think interferon overall is a matter, and we have to study further deeper to see if both interferons alpha and gamma, or only one of them, are important for the disease.
Christos, I have one question about the case you were referring to. Do you know if she's still treated with anifrolumab, or if the treatment was somehow stopped, or how is she?
She's alive, at least until the 29th of December. It's a very, very peculiar, very, very unhappy situation. She's tetraplegic. She has huge problems but she had incredible parents who support her at an incredible level, and she's continuously treated. We don't have at the moment a progression. So under the treatment, we have now several years of stable disease, but no improvement, unfortunately. And probably this is because of the scars that are already existing in all organs, including the central nervous system. But we don't have a worsening. This is what at least her mother told me on the 29th of December.
Okay, but she's if now one mutated, so it could be considered as a very specific situation in which anifrolumab would be particularly efficient. But still, we don't have so many case reports to rely on, so it's very important. There is one question in the chat, which is basically the one you discussed with Dr. Baum. Basically, I would like to ask any suggestion on how to differentiate MAP from BAP. And he or she speaks about a pediatric patient with skin involvement, as far as I understand, and conjunctival hyperemia, glaucoma, symptomatic intracranial hypertension, resulting in optic nerve compression and papilledema of the left eye, but it's unclear whether these manifestations are related to benign or malignant form. What would you think, Chris?
I personally think that this is involvement of the disease, especially if it's at one eye. But again, as already discussed with Manfred, I would consider it still as benign type.
Because it's the specific localization of the eye with the skin. Okay, yeah, okay. And I have in mind, you always, there is one clinical case that we'll discuss after that. It's a patient that was discovered in the reanimation unit. And do you have patient? I don't know if you discovered a patient, you have skin, GI, CNS involvement all at the same time. So you basically think it's acute, but do you have patients like this in mind? And are you able to know if they had like skin involvement undiagnosed for many years before being in the medical system?
The majority of the patients have initially skin disease, but not all. Looking at pediatric patients, especially, we have found that they had systemic disease before developing skin lesions. As far as the developed skin lesions, there is security that this disease is there. And again, I say clinically, it's very clear that this is a disease. I don't think we need the histology, and the histology, whatever, even if the histologist is not informed and he's not dermatohistologist, he will not say anything. The clinical pictures that makes a difference. I had two patients up to now. That's just by chance. They asked us if we would like to, actually, they asked us for a tumor, to look for a tumor, because the patient were at the intensive care with central nervous disease. And usually, of course, we see the entire body, and we have found the lesions. So it's not a melanoma, as the colleagues thought, but it was malignant atrophic papulosis.
I still have one question, Axel. It's about the presence of anticardiolipin antibodies and anti-beta-2 GP1 antibodies. Do you think these antibodies are the consequences of endothelial cell injury, or they are participating in the thrombosis of the disease?
As you much better know than me, it's a matter of levels. What we get are not high levels. We get about 20. This means probably it's a consequence of the endothelial damage. In order to say they participate, I expect 100. In that case, I would say they are involved. I did not have any patient with that level, at least with patients with cutaneous involvement only.
Yep. No more question. No more question in the chat, Axel?
No. There is a comment by Christine, but it's not a question.
Okay.
So I think we're okay.
Okay.
Thank you so much, Christopher, for this excellent lecture and all your input for this very rare disease.
I thank you very much, and excuse me for having to leave because I have to go to the university for a meeting that acutely yesterday I have been involved in. So all the best, and again, thank you so much for this wonderful meeting.
Thank you, Christos.
Thank you, Christos.
Thank you.
So now we will give the hand to Degos Disease Foundation, and maybe before the clinical cases, Christine, and so we will know more about that foundation, and several people from the foundation will speak about the foundation: Anna Bowen, Samantha Sattel, Sumia Martin Afridi, Dr. Leo Shapiro, and people coming from the NIH, I think. So, Lee, it's your turn now. Give you the hand.
I thank you so much for this excellent, outstanding meeting, incredibly high level and so informative. And thank you for including us. I just, before I hand it off to the speakers, I just wanted to make a couple of editorial comments. And one is, although there is almost universally, not universally, but almost this long history of preceding skin lesions, still, of the inquiries that we receive, so many present in a catastrophic state. So one of our speakers is going to talk about what are other dermatologists calling these lesions. And of course, there's some people who don't go to the dermatologist because they're not troubled by them. But we have often this long window where we could be evaluating the patients, and yet so many present catastrophically. And speaking of that, I also have the sense that when there is systemic or so-called malignant atrophic papulosis, there are different speeds. So there are people who can present with isolated ocular involvement, as discussed, or gastrointestinal perforation. But there are other people who present as almost a Degos storm, where there is simultaneously active neurologic, gastroenterologic, cardiac, and ophthalmologic disease. And they are the people who need the most intensive therapy. And one question which we won't be able to resolve today is whether the intensity of the treatment can be varied over long term without risking resumption of such catastrophic events. So the foundation actually is outgrowth of the website first developed and the community first developed by Judith Calder, a patient who felt when she was first diagnosed in England that she might be the only person in the world with the disease, and she was certainly one of only several dozen people with the disease recognized at that time. And she developed a online community, which we've tried to expand over time. And we will talk about that, but we have 4 speakers, and each one will introduce the next. So the first is Dr. Samantha Sattler, who is completing a dermatology residency at the State University at Stony Brook. And she is the lead author on the paper that was cited by Marie on gastrointestinal manifestations. But she is going to speak about what are the diagnostic errors that cause that 2-year wait? What are other dermatologists calling these lesions? So thank you, Samantha.
Thank you, Dr. Shapiro, for the introduction, and it's a pleasure to be here and to be speaking with all of you at this great conference. So the reason that we thought this topic would be fitting is because, as Dr. Shapiro mentioned, Degos disease is often missed, causing delays in diagnosis, and that's likely because it is not commonly on a differential diagnosis given its ultra-rare occurrence, but also because it has mimickers both clinically and histopathologically. So in my talk, I will discuss how to distinguish Degos from other cutaneous diseases that may cross the mind of a clinician who is seeing Degos for the first time. And not included in my talk are overlaps with Degos and diseases like dermatomyositis and lupus, which Dr. Marie Robert covered very well in her earlier talk. So to review the classic appearance of mature Degos lesions, they demonstrate an atrophic and avascular porcelain white center with an erythematous border. They occur most often on the trunk and upper extremities, often sparing the face and hands, and since they can be few in number and asymptomatic, they might be missed. Jumping right into the clinical mimickers of Degos disease, the first I will discuss is dermatofibromas, also called fibrous histiocytomas. They are benign skin neoplasms that often occur as scar-like lesions in areas of prior trauma, and they can be distinguished from Degos due to their rim of erythema and hyperpigmentation rather than pure telangiectasia, as well as a central scar that exhibits dimpling when pressed between the fingers. The patients can be covered in multiple of these and not remember the source of trauma, and so they might be mistaken as Degos. The second diagnosis I'll discuss is lichen sclerosis et atrophicus. This condition more commonly occurs on the anogenital region, where localized inflammation can lead to skin atrophy if left untreated. However, there can be extragenital involvement of skin near the anogenital mucosa, in traumatized skin affected via Koebner phenomenon, or in follicular here. While classic lichen sclerosis is more commonly symptomatic, extragenital LSA can be asymptomatic or slightly pruritic like Degos. However, it can be distinguished from Degos by the distribution and the often co-occurrence with genital LSA. Atrophy blanche is the end stage of livedoid vasculopathy, which is caused by vasoocclusion of the cutaneous microcirculation. These avascular sclerotic plaques can be distinguished from Degos as they occur in areas of poor vascular flow, so commonly on the lower extremities, and therefore they would be seen in the setting of surrounding retiform purpura or with other clinical signs of poor vascularity such as pallor, coolness, or decreased pedal pulses. Pityriasis lichenoides chronica is the chronic version of pleva, or pityriasis lichenoides et varioliformis acuta. It presents with crops of erythematous papules with central scale, and it's commonly seen on the trunk and extremities. A variant of pleva, Mucha-Habermann disease, is marked by larger, more ulcerative and necrotic lesions, as well as systemic symptoms that may mimic systemic. Distinguished from Degos, as Degos lesions are neither scaly nor as largely necrotic. Lymphomatoid papulosis is an entity that exists on a spectrum with primary cutaneous anaplastic large cell lymphoma. Both are CD30 positive cutaneous lymphoproliferative disorders, but LYP follows a benign clinical course. And clinically, this is distinguished from Degos due to the recurrent, chronic, and often self-healing nature of these papulonecrotic or nodular lesions. Idiopathic guttate hypomelanosis. This occurs as scattered hypomelanotic macules on chronically sun-damaged skin due to a reduction in the number of melanocytes in the skin. And to the trained eye, this is easily distinguished from Degos due to the lack of any skin atrophy. Atrophoderma is caused by idiopathic dermal atrophy, and it causes the appearance of round, smooth, atrophic depressed plaques with sloping borders. It is the classic cliff drop borders that help distinguish this entity from Degos. And lastly, in many case reports, Degos was initially diagnosed as molluscum contagiosum. This is a viral skin infection caused by DNA pox virus, and clinically, these smooth, firm papules can be distinguished from Degos by their classic umbilication and a central core that is often present on mature molluscum lesions. All of these aforementioned diseases can be distinguished from Degos histopathologically as well. So briefly, I just want to touch on areas in which a pathologist may miss Degos as a diagnosis. Classic Degos pathology demonstrates an attenuated epidermis with a subepidermal wedge-shaped fibrosis and vascular dropout that's been previously mentioned in these talks. So to the right, I show a shave biopsy of Degos disease read by my institution's pathologist. And the reason why I like this biopsy is because it demonstrates the reality of what pathology often receives: a thinner single specimen rather than a deeper punch. Looking at these photos, we can imagine how if the pathologist only received a specimen including this leftward portion, you would see interface dermatitis with an acute stratum corneum that may make one consider a brisk interface dermatitis such as erythema multiforme or acute graft versus host disease. If the pathologist only sees atrophy in the specimen, then morphia, scleroderma, or atrophoderma might be considered. If only lymphoid vasculitis is apparent in the planes of section, then insect bites, rickettsial disease, or pityriasis lichenoides may be considered. Thus, we recommend obtaining a punch biopsy, including all of the Degos lesions, so the center, the rim, and adjacent normal skin, to best aid diagnosis. And of course, noting Degos in the differential helps the dermatopathologist make that clinical pathological correlation more effectively to hopefully cinch the diagnosis. Thank you all for your time. Next, I would like to introduce Dr. Soumya Afridi, who is an attending rheumatologist at Albany Medical Center, and she will be speaking on the follow-up of long-term survivors of systemic Kohlmeier-Degos disease.
Thank you, Samantha, and thank you for giving me the opportunity to share this very important project with everyone. So we will be discussing about a qualitative study that we have been doing on long-term survivors of systemic Degos. So the purpose of this study, the purpose of this study is for us to characterize quality of life and patient-reported experience among long-term survivors of systemic Degos. And I do want to highlight that this study is basically, we have only included long-term survivors of this condition in our project. We do want to understand how these survivors are navigating uncertainty, treatment burden, and long-term survivorship in this rare life-threatening condition. One important point that we want to highlight is that long-term survival is possible in systemic Degos, especially because when we look up the literature, so far there have been poor outcomes reported. And one of my patients did mention that they thought they had 2 years to live. Talking about the study design, it's a qualitative descriptive study of adults with systemic Degos. Long-term survival was defined as 5 or more than 5 years after the onset of systemic disease. Our participants completed a structural health questionnaire, and we also conducted virtual interviews with all the participants. So patient characteristics and their diagnostic journey. So far, we have 4 participants, and we do plan to include more in the future. 3 females and 1 male. The average age at diagnosis is between 17 to 52 years. Their disease duration is from 8 to 16 plus years. All the participants they, had the initial skin lesions as an initial presentation. All of them did. From skin to their systemic involvement, it took somewhere around months, up to 3 years, to have systemic involvement, even though some did mention that they had some sort of GI symptoms before they were diagnosed. So this is going to be a range. Time to diagnosis, and that is time from their skin lesions up to diagnosis. It took around 1 to 2 years for them to get the diagnosis of Degos. They had seen multiple providers and different specialists before they were diagnosed, somewhere between 2 to 6 different specialists before the diagnosis was made. All of them had seen dermatology, but some had also seen GI as well. Talking about systemic involvement, all of these 4 participants have skin involvement and GI involvement, but others also had cardiac, pleural, and ocular involvement as well. And I do want to highlight that none of these participants had a neurological disease. Talking about hospitalizations, 3 out of 4 participants had hospitalizations related to Degos, and that was present in patients who had delayed diagnosis. The main reasons for hospitalization was GI perforation, bleeding, and pericardial involvement. Early initiation of therapy was associated with fewer severe complications in these patients. But regardless, despite survival and in some cases, despite getting treatment, they did have permanent morbidity. One had ileostomy and the other one had vision loss in one eye. Treatment and access challenges. All 4 of these patients, they are on eculizumab and aspirin. 3 out of 4 are on treprostinil. 1 is on subcutaneous, 2 on oral form. They had good response to eculizumab initially from somewhere between days to months, and they noted rapid improvement in their GI symptoms. They also noted improvement in their skin lesions, and that was noted more after addition of treprostinil. All 4 participants had to deal with insurance barriers, required multiple appeals, delays, or compassionate use by the drug company. One of the participants had to wait 2 years for insurance approvals and got the medication after multiple appeals. Most of these participants had treatment interruptions, and that was again because of insurance issues and delay in getting treatment. So these 4 participants, they sustained survival for 8 to 16 plus years after their disease was diagnosed. They did achieve functional independence. They have returned to work with meaningful activity. 3 out of 4 are working full-time right now, and 1 recently retired. They have stable disease on long-term therapy, and this survivorship does require ongoing treatment and vigilance, not only from providers' end, but also from the patients themselves. Talking about psychosocial impact of this condition and what they've been through, common early themes noted were isolation, fear, lack of reliable information. Almost actually all of them went on internet to try to search about this condition. Over time, they developed resilience and adaptive coping skills. They had strong reliance on support system, not only from their friends and family, but also from their treating physicians. Most of them started to take up advocacy roles. For example, they're involved in awareness efforts, peer support, try to make sure that others who are diagnosed with this condition have access to resources. So talking about their quality of life, there have been impacts on their physical health. Even though they do feel better, they do have some ongoing GI symptoms. They do have persistent skin lesions despite disease control. There are permanent sequelae in some, for example, ileostomy and vision loss that we discussed. They have to deal with treatment burden with lifelong commitment to infusions or continuous therapy. They are dealing with side effects and infection risk due to immunosuppression. They have anxiety related to the disease recurrence, fear of getting the disease again, or fear of losing access to medication. They do have psychological impact from their early traumatic medical experience, especially when they were going through the process of getting diagnosed with procedures and multiple testing without knowing what they had. They do have impact on their social and occupational life. They have had career modification as well as change in their retirement plans with this condition. So they do have to plan daily activities around their symptoms and treatments. So to summarize key takeaway points, what we want to highlight is that long-term survival in systemic Degos is possible. Delayed diagnosis remains common, and it is clinically consequential and can be life-threatening. Access to target therapy is very important, but it can be challenging, especially because of insurance issues. And survivorship is not just disease control, but it also extends to quality of life and purpose. And thank you. I'm happy to take any questions.
Questions now or just at the end? Is there somebody else who is presenting something or not?
Yes, so I can hand it over to Hannah Bowen. She's our research coordinator of Degos Disease Foundation, and she will speak next on inquiries received on degosdisease.org website.
She's not there, or?
Sorry, I was on mute. Can everyone see with that PowerPoint?
Yes, perfect.
Perfect. Okay. Hi, everyone. Thank you so much, Sumaya. And I would also just like to say thank you for this opportunity to present. So in my presentation, I will be discussing the Degos disease inquiries that we have received over the last 5 years. So for the purpose, our foundation has been tracking information on Degos inquiries, specifically location of inquiry, country, and state within the US, also who is inquiring, and then the nature of the inquiry. So this is a screenshot here from the new and improved Degos disease website, where patients, caregivers, physicians, researchers, students, and others can contact us to ask us questions, share their story, request guidance, investigate support groups, and things of that nature. And we try our best to respond as soon as possible. Okay, so on this next slide, so we still receive the majority of inquiries via email sent directly to Dr. Shapiro. We've also received inquiries via the old Degos website, which would be prior to October 1st of 2024. And then we've also received an inquiry from a pediatric rheumatologist through the recently published up-to-date chapter by Dr. Patrick Whalen and Dr. Lee Shapiro. And then if you look to the right, you'll see the country breakdown with the majority of our inquiries coming from the US. And then in the next slide, I'm going to show a geographical representation by country and also US state. So you'll see the darker shades of blue indicate a greater number of inquiries received in that area. So we have received inquiries from 16 different countries and 15 different US states within the last 5 years. Okay, moving on into who is inquiring. So we have received inquiries, as I stated earlier, patients, physicians, caregivers, students, fellows, and also a friend. So I split out caregiver and partner, as you'll see on the table from the left, as the caregivers are not partners, and that was specifically stated in the inquiry information that we received. And the majority of inquiries are received from patients and physicians, as you see in the chart in the middle. And then on the table to the right, you can see the specific breakdown. So physician specialty, caregiver type, student level discipline, and then also the breakdown between fellows. Okay, and on this slide, you can see in the chart on the top left the breakdown of inquiries over time starting in 2020 when we began to track inquiry data through current day. And most inquiries received Degos diagnosis had been confirmed through their physician and biopsy. And in a few cases, Degos was suspected but not confirmed. And this could also include that they did receive a biopsy, but they were pending the biopsy results. We also received 2 non-Degos inquiries from patients inquiring about Dowling Degos who had accessed the website, not realizing that it wasn't specific to Dowling Degos. Then we also received 1 educational inquiry from a pharmacy student from the University of Reading, Berkshire, asking for assistance on a Degos-focused project regarding treatment. And then I'd also just like to highlight, you may notice the increase in 2025, the number of inquiries that we received. And we may be able to attribute this to the new Degos website, because once we were able to complete the new website, individuals could use the Contact Us section directly, or they may be able to get Dr. Shapiro's email from the Treatments and Care page as well. So moving into the data analysis, so to analyze the data, I completed a thematic analysis, pulling out the 4 main themes. So as you can see, we have emotional or psychological, which includes anxiety, fear, depressed, hopelessness, and then seeking information, which includes guidance, expertise, disease progression. And as you can see, I specified those even further, depending on the nature of the inquiry. And then also access, and then the sub-themes would be geographical limitations, immediate treatment needs, so the urgency, insurance denial or insurance approval, and then provider unfamiliarity with the disease. And then lastly, disease overlap, so comorbidities and interdisciplinary care needs. So then on the next slide here, you can see a little bit more of a detailed breakdown. So the majority of the inquiries that we have received for the main theme of seeking information is 65%, and then going into access, emotional, psychological, and disease overlap. And I would like to note here that there may be multiple themes for 1 inquiry, as we did have several inquiries that hit on even four of these themes. And then in this slide, I'd just like to highlight, we also tracked whether the Degos diagnosis, if they were recently diagnosed or if they had reached out after they've been diagnosed for a long time. So by definition of recently diagnosed would mean that they received a diagnosis less than 1 month from inquiring. And so 51% of patients had not been recently diagnosed. And then in the chart in the center here, we also tracked whether the patient was in crisis. So by definition, this would be evidence of active systemic disease or urgent treatment needed. They were experiencing GI symptoms and had not yet received a laparoscopy. And as you can see, 56% of our inquiries, patients were in crisis. And then lastly, here on the right, we also tracked whether the inquiry highlighted or stated if it was a drug access challenge. And by definition, this could mean insurance denial of their treatment, geographic location, or in need of immediate drug access. So for example, if their treatment was stopped, and 78% of patients did not indicate that it was a drug access issue within the inquiry. So lastly here, I pasted in a link to our Degos disease website, and the content is up to date. And you can also write Dr. Shapiro if you have suggestions on modifications to make the site more useful for patients or physicians or caregivers. Our goal is to reach a global audience, so we're currently looking into how to address the issue of language translation. But I would just like to say thank you, everyone, for attending and for the opportunity to present. So if there's time now, we can do questions. If not, I would like to pass it over to Dr. Kujici from the NIH to present on research updates.
Yes, maybe we can continue and resume and keep the question at the end.
Hello, I need to share my screen. Thank you so much for giving us the opportunity to present our work. trying to. Just want to know if you can see my screen.
Not full screen, but yes, perfect.
Okay. My name is Cornelia Kudrich. I'm an adult rheumatologist working at NIH under Dr. Manfred Boehm labs. We are part of the cardiovascular regenerative medicine and branch and part of the NHLBI Institute. There are several institutes in NIH, and this is the Cardiovascular Institute. Then this is just a very brief presentation of systemic Degos disease, Kohlmeier-Degos disease. I know this was discussed before. I'm just going to go very briefly to these slides. Systemic Degos disease is a rare vasculopathy with multiple organ involvement. This is a high fatality. It's very high in these patients and occur about 2 or 3 years after diagnosis of systemic disease. There are multiple systemic manifestations. The most common one is a GI manifestation in more than 70% of the patients with systemic Degos disease. CNS manifestation seems to be a second cause, can be present in about 50% of the patients. But also the overlap between gastrointestinal and CNS neurological manifestation is present in more than 60% of the patients. Then are other additional manifestations, including pericardial, pleural, musculoskeletal manifestation, ocular, and GI manifestation. And this is a few lesions from the skin disease and one of our patients with severe gastrointestinal involvement. Now, neurological disease was described as having many manifestations, including hemorrhagic strokes, ischemic lesions, subdural effusion, thickening of the meninges, meningeal enhancement, but also involving the cord, the spinal cord with polyradicular neuropathy with multifocal lesions, myelitis, the various cranial nerve palsy and affecting and causing urinary incontinence. Here on this side, we do see several manifestations of the Degos disease. I want to mention, I think in my perspective, probably some of the manifestation occur early on. I do believe the meningeal enhancement is kind of one of the early manifestation of the neurodegos, and followed by other manifestation which can occur later on after the more extensive disease. But again, the natural history of the neurological disease is unknown. Now I'm going to start with a case where our interest to neurodegos started, and this is a 58-year-old Caucasian male who was starting having first lesion in about 2010. He had multiple biopsy over time, but no diagnosis was done. 8 years later, he developed neurological symptoms. He started having left foot paresthesia. He did describe as a cotton ball after on the foot, but then start having more symptoms, including sciatica type of pain, followed by lower extremity weakness. Then short after, he developed hearing loss, was hard for him to walk, and the neurological symptoms progressed very quickly, affecting him his right leg, and also short after he developed bowel and bladder incontinence. He had an extensive workup done, including neurological and rheumatological workup, including multiple MRIs, lumbar puncture, which was only significant for slightly increasing protein and IgG. Everything else was normal. He had a biopsy, including peripheral nerve biopsy, which was showing axonal loss and microangiopathy. EMG show polyradiculoneuropathy. He was started on multiple dose of steroids and azathioprine with no benefit. In 2021, patient was finally diagnosed with Degos disease, and I have to mention here Dr. Magro was like extremely helpful and help us with diagnose the Degos disease. And MRI showed multiple leptomeningeal lesions. He was evaluated at NIH in 2021. He did have minimal GI symptoms, almost some very vague abdominal pain, but we did consider this in setting of steroids, very typical for GERD. But to our surprise, laparoscopy was positive for Degos lesion, has many lesions, and we started him on eculizumab. Patient initial neurological symptoms and skin lesions seems to get better on eculizumab for a few months, but he continued to have lower extremity weakness and the disease progressed. Then he was basically confined in a wheelchair. He was, in the same time, short after eculizumab, he was started on treprostinil, again, with maybe some improvement. I think he described like mostly like brain fogginess was improved after eculizumab and treprostinil, but unfortunately his neurological symptoms got worse. We try different things, including high-dose steroids. I will, because the disease progression based on that MRI, and we use a very high dose of steroids. We use the MS dose, just want to mention, with some improvement, at least temporary improvement. Now, meantime, we did perform a lot of research blood and also along with the clinical blood, and we did single-cell RNA-seq. We performed single-cell RNA-seq from the skin lesions. And as you see here, this is an acute Degos lesion. As was mentioned before, Degos lesion can have various, could be acute, could be, and become scars, but this is an acute lesion with a histopathology showing here perivascular inflammation. And the single-cell RNA-seq show us both in lymphocytes and on endothelial cells, and interferon signature persistent for both these type of cells. Type 1 interferon alpha and beta signaling was increased, and also, but also in the lesser extent, type 2 interferon, interferon gamma signaling was high in these cells. For these patients, we, along with the skin's biopsy, we did also a spinal fluid and PBMCs, blood, single-cell RNA-seq, and in all this tissue, we did have an increase in type 1 and type 2 interferon, and seems also because of the single-cell RNA-seq, we did saw the CD8 T cells are the one who are producing type 1 and type 2 interferon, and possible these cells are involved in the pathology. And both type 1 and type 2 interferon are affecting endothelial cells and the blood cells. And because of this, we did come with the, ruxolitinib or baricitinib JAK1, JAK2 inhibitor, which are blocking both type 1 and type 2 interferon, and see if this medication will help the patient. And this is a very briefly, we create this single patient study, a clinical trial, which was the first one done in Degos patients, where we have our patients with both GI and neurological involvement. At the time of the trial, patient was already on eculizumab, and we start patient on ruxolitinib. And this was his MRI prior the study initiation, prior ruxolitinib, and also the skin biopsy. And 3 months after patient's skin biopsy result, most of his erythematous edges around the Degos lesion were resolved, and also the Degos lesions on the CNS seems to, some of these lesions were improving, another or getting smaller, other lesions were disappear. 12 months after the medication, again, we observe a stabilization of these lesions. Now, along with the clinical trial and the clinical evaluation and the MRI, we did run interferon score in these patients, and both type 1 and type 2 interferon. We use as a control healthy controls, and also very high patients with very high type 1 and type 2 interferon score, like Kendall and Savvy patients. And as you see, the Degos patients, Degos patient has a lower level of interferon score, but with ruxolitinib, even after a week, the interferon score went down to normal, and we're able to maintain the score low over the clinical trial. Now, a patient was extremely sick at the time of clinical enrollment. He was diagnosed with COVID and was bedbound, has many complications, but patient it's right now still alive, and even the neurological symptoms were not improved. He lost his ability to walk, but we feel like the trial demonstrate that JAK-STAT inhibitor was useful in controlling the disease, even not able to reverse his neurological symptoms. These are some adverse effects from the Ruxo trial over the 12 months. I think the main one was anemia. Patient has anemia at the baseline. Again, he was very sick, has a stage 4 sacral wound, and continued to have anemia, and the anemia kind of got worse over the clinical trials. We're not convinced that the anemia is due to ruxolitinib, but at the end, I think was probably a factor of the ruxolitinib was contributing to his anemia. He received about 6 units of blood over a year. He did also had the urinary tract infection and sepsis, but this was in the setting of a Foley catheter. Patient start the clinical trial with a Foley catheter and severe sacral ulcer, unstaged sacral ulcers, and he was depressed, and this was another things which kind of reported as a part of the clinical trial side effect. Now, based on this clinical trial, we'll design this second clinical trials on more patients, where it's also the phase 2A clinical trial. We're planning to enroll 6 patients with a neurological involvement and use baricitinib 4 milligrams. In addition to the background therapy, we like to continue eculizumab if the patient needs eculizumab, and add a JAK-STAT inhibitor in addition to the eculizumab. And we designed the protocol in the way like every patient should be their own control. They will be followed for about 12 weeks on the background therapy, followed by 6 months of baricitinib 4 milligrams daily. Then the study objective will be to see if the baricitinib will be able to attenuate type 1 and type 2 interferon signaling, and hopefully will slow and halt or decrease the neurological symptoms, the disease progression. And this is another schematic of the patients, where the primary endpoint will be the MRI of the brain and spine. I'm going to try to evaluate the neurological involvement it's very, very hard to quantify this lesion because these lesions seems to be very small, very discrete. And I also want to mention the MRI. We do the MRI with a contrast, gadolinium contrast, because sometimes the regular MRI did not show these lesions. And we're gonna, as a secondary endpoint, we're looking for neurological involvement, clinical involvement, how they behaved over time, self-reporting physical function, pain, fatigue, and health-related quality of life. And this is my acknowledgement slide. Again, we are part of Dr. Boehm team, and also we have a big clinical team involved. Mentioned here, along with Dr. Boehm, Dr. Rosing, and Dr. Rafael Golbamansky, which is outside NHLBI collaborator, and NIMS, Dr. Nagao, and our very close collaborator, Dr. Shapiro, Dr. Magro, and Degos Foundation. I'm happy to answer any questions.
Thank you. Do we have somebody else taking and presenting something from the Degos Disease Foundation? Yes or no? Lee, are you there with us? Or it's okay?
Yeah, we are done.
Okay, it's done. Fine, nice. Thank you for this different presentation to be on time. We still have just 3 minutes for discussion. I have one or several questions. First of all, congratulations to Anna Bowen for the well and great work done on the website. It's fantastic, and thank you for that. Thank you for the patient too. I have a question for Dr. Sattler concerning the biopsy. Should we perform the biopsy directly in the center of the lesion, in the white aspect of the lesion, or in the border, or both?
Both would be ideal, a punch biopsy with enough, millimeter circumference to reach around both. That would be most ideal. And if you can even get a little bit of the surrounding tissue, even if it's just a millimeter to see the border of transition, that would be the absolute best.
Okay. And do you have experience about expression of interferon signature on the skin biopsy and experience on deposit of complement component?
So I am by no means an expert in that. I think, Dr. Cynthia Magro or somebody would be better for that description, unless Dr. Shapiro, you want to comment on it as well. But I wish I was more of an expert on that. I only know from Dr. Magro's work.
Okay. A question for Dr. Afridi. So there is a comment for you in the chat. Devrait partir à 17h45. The comment is it's amazing that we have very few knowledge about the psychological burden coming from a patient with Degos disease. So it's a part of your work, I think.
Yes, so we actually had talked to these participants, and we plan to continue to do so in detail about psychosocial impact and how much they're affected, what their initial feelings were, for example, when they were diagnosed, with their coping mechanisms. We did use a very detailed questionnaire asking multiple questions about psychosocial impact, especially related to disease burden, getting diagnosed, and obviously anxiety and frustration around that part too. So yes, it is a very important part of our project. And when I was actually interviewing these people myself, I was very surprised to hear all these stories. One of them actually kept researching so much online that ended up getting the diagnosis, getting close to the diagnosis herself, actually. So this is a very important point.
Okay, so thank you. I think we have to stop the question, unfortunately, because Axel you have very short time to present the next clinical case. So I give the hand to Christine BODEMER to introduce 2 clinical cases.
Thank you very much, Eric. So it's a pleasure, Axel and Marie, to hear you again for these two clinical cases. I think that we can begin without losing time, and after that we will keep all the questions after the two cases. Axel, is for you.
Thank you, Christine. Marie, you have the slides, can you? So we're going to present two clinical cases, and then Emmanuel will present his very interesting case. So I will take a very few minutes. It's a dermatologist case, let's say, and then you have a more severe case. So the first one is a woman, 60 years old. For 18 months, she's been presenting with skin lesions, and she was referred to the dermatology department. And you can see, of course, the typical clinical lesions that she had on the trunk, and we performed the skin biopsy. We can go on because we discussed that very largely. So for the next 10 slides, I have very nice pictures, and I just wanted to put them because you can make your eye with this. So you can see different stages. You can go on, Marie. Different stages. Sometimes the purpuric ring is more pronounced, sometimes less. Sometimes it's more umbilicated, sometimes it's less, and it can affect the legs, it can affect the torso, can affect the breast. So the diagnosis was benign atrophic papulosis, Degos disease, with cutaneous limited form of Degos disease, no GI, no neurological or other systemic involvement. Is this one of your slides, Mary?
No.
No, okay. No, that and basically we have a probability of benign cause that increases over the time. We discussed that with Christos. 97% likelihood of remaining benign after 7 years. And Christos said the first 2 years are one of the first step to reach. You can go on, Marie. And for this one, basically, she experienced at some point paresthesia and sudden visual field defect. And then she was assessed with an MRI, and she had some preliminary lesions. The punctate flare hyperintense lesion of the white matter in the centrum semioval. It was non-specific, but given the context, it was considered as compatible with the Degos disease. And she had transient retinal ischemic scotoma that was also considered to be associated with the Degos disease. So it's compatible with an evolution from BAP, benign, to malignant. And as we discussed before, it's important to evaluate regularly these patients, even if they don't have any symptoms, because you can be falsely reassured with just very visual skin lesions, and sometimes the other symptoms are very sparse. Marie, it's up to you.
And thank you, Axel. I will go on with the second clinical case. It's quite interesting because it happened in 2013. So before the era of eculizumab and other interferon inhibitors. So again, it's a woman of age 60 years old with no remarkable medical history. We experienced 10 days of abdominal pain and diarrhea. So she went to the emergency, and a CT scan revealed some ascites and bowel wall thickening. So given the severity of the clinical manifestation and of the CT scan, the patient underwent exploratory laparotomy, which revealed this kind of lesion that we have already shown some example before with multiple porcelain, white infarct, as you can see there or there, without at that time any signs of perforation. So 6 days later, the patient presented a structural perforation. There was no sign of autoimmunity or infection. And so at that time, the diagnosis was still unknown. Then the physician observed on the lower limbs this kind of skin lesion that now you know very well, and that were compatible with atrophic papulosis. So I won't detail more the histopathology, but it was compatible with the Gauss disease, given also all other clinical manifestations presented by the patient. So after that, the patient was treated with heparin calcium and iloprost, but unfortunately, there was a worsening of her GI involvement, and so iloprost was switched for treprostinil because in 2013, this paper came out from Lee reporting two patients who were improved by treprostinil. So at that time, it was decided to try this treatment, and the efficiency of this treatment may rely on the enhancement of endothelial progenitor cells and promote angiogenesis. So because of that, of this 2 case report, the treatment was tried in our patient, and unfortunately she developed then CNS involvement with multiple stroke and cerebral vasculitis. And unfortunately, the patient died 3 months after the initial GI manifestation. So we believe that this clinical case report was interesting. It was before 2013 with first manifestation with GI involvement, and then the asymptomatic skin lesion. Either they appear or maybe they have been missed initially, and treprostinil was tried because of the 2 case report published in the same year. So now therapeutic approaches have evolved, and Emmanuel Ledoux will describe them in his case report.
Y a-t-il un problème? Is there a problem?
So just, do you see my screen?
Yeah, but yeah, it's better now.
Okay. Oh. Okay.
Perfect.
Great. So thank you for giving me the opportunity to share this clinical presentation. So it's a case of a young male with no past medical history, who complained about 1, then 10, then 20, 50, up to 100 atrophic papules on the trunks and the upper extremities, leading to a diagnostic of beginning atrophic papulosis a year after disease onset. This diagnosis was made by a dermatologist, and the skin biopsies was consistent with this, with atrophic papulosis. At this time, there was no sign of systemic involvement, but it was not the case 6 months later, when he complained of a visual disturbance, and we understand it was related to retinal ischemia a few months later, when we first met him in our center. And you can have a look on the panel at the bottom. This retinal ischemia was exactly localized in the opposite on an area of conjunctival ischemia. It's the panel of the middle, and responsible for nasal damage on the wide visual field. In the same time, he complained of ptosis, diplopia, and that was related to infiltration of the orbital fat and the oculomotor muscles. When we first met him, we checked the brain and we also found multiple strokes. So the skin was involved, the eye was involved, and the gastrointestinal tracts were also involved. In fact, we complained of abdominal pain at the same time of the eye involvement, leading to a coloscopy. I think it was in December 2023, showing multiple millimetric ulcerations, as you can see on the panel at the upper panel. And unfortunately, a month later, he was admitted in our center for peritonitis. So when we first met him in January 2024, the diagnosis of Degos disease was also already made. So we checked for differential diagnosis, but the etiological workup found no sign of overlapping with autoimmune disease, no evidence of viral or bacterial triggers. The blood antifungal signature was very high, much higher than we usually observed in lupus, for example. So how did we manage the disease? So just immediately after the surgery, so with antibiotics, aspirin, and prostacyclin analogs, we use ilomedin. And just a few days later, eculizumab was started. But look at that. I think it's important to note we need almost 3 to 4 weeks to obtain a full inhibition of the complement. We checked the brain. So a second brain MRI was performed almost 3 weeks after the admission at in our center, and we noticed new strokes. And in the same times, due to worsening of the abdominal pain, a second surgery was done, and we found new multiple microperforations needed to an ileostomy. So at this time, we decided to stop prostacyclin, to continue eculizumab, and we reserved, in fact, the result of the blood interferogen score. And due to the very high level and the evidence in the literature, we started anifrolumab, 3 milligrams every 4 weeks. And we added baricitinib when a oral intake was feasible, so I think it was 4 or 5 days later. And the rationale behind this upfront maximal combination therapy was to target both the interferon in the bloodstream and the already activated interferon-mediated signaling pathways because the disease was rapidly progressive and life-threatening. But I think it's important to note that the patient told us just 2 or 3 days after starting anifrolumab and before starting baricitinib, he noticed early improvement of the ptosis and of some of the skin lesions. So since then, no relapse occurred. But I think 2 weeks after starting baricitinib, we noticed an increase of the interferon score. So we decided to bring the next infusion for bio-week and to increase the following infusion of anifrolumab up to 900 milligrams every 4 weeks, and that based of the safety profile of this dosage in the MUSE trial in lupus. And we observed a slow normalization of the blood interferon score over time. So that is 4 months after admission in our center. So compared to baseline, we notice improvement of the skin involvement, the eye involvement, the brain involvements. So we decided to switch eculizumab to ravulizumab for convenience. And 9 months later, we decided to stop baricitinib, and we observed that the blood adhesion score remained low and no signs of relapse of the disease. So we decided to remove the stoma, and that is 6 weeks after the stoma removal. As you can see, he has weight. No signs of relapse of the disease, and today, so it's 2 years later, and it's the same without the dressing, of course, and it works again. So the next challenge, I think, it's what should we do with this treatment? Should we keep it like that? Anifrolumab 900 milligrams every 4 weeks at home, and revilizumab every 2 months in our center. Or should we consider to withdraw revilizumab, taper anifrolumab? We don't know. Thank you for your attention.
Je m'appelle Jonathan, j'ai 39 ans, je suis atteint de la maladie de Degos et je suis passionné de photographie. Les premiers symptômes de la maladie, c'était des lésions qui sont apparues sur la peau. Les problèmes de vision sont apparus en un second temps. Des problèmes digestifs sont apparus sous forme de colite. Et on a même suspecté la maladie de Crohn. Alors j'ai vu plusieurs dermatologues. Le premier m'a orienté plutôt sur un molluscum. Voyant le traitement qui ne fonctionnait pas, j'ai consulté un dermatologue en Belgique. Elle m'a interrogé sur d'autres problèmes que je pourrais avoir, si j'avais des problèmes de vue, des problèmes de digestion ou des problèmes au niveau du cerveau. Et suite à ces questions, elle s'est orientée vers la maladie de Degos. Entre les premiers symptômes et le diagnostic posé, il s'est écoulé 18 mois. Alors, la première fois qu'on m'annonce que c'est la maladie de Degos, j'ai pas spécialement peur car la dermatologue est très rassurante en me disant textuellement que ce n'est pas un cancer. Donc je me suis pas alarmé d'emblée. C'est qu'en rentrant chez moi, quand j'ai commencé à effectuer mes recherches, que j'ai commencé à avoir un petit peu peur. Parce que les résultats des recherches sur Internet sont très pessimistes et envoient cette maladie vers une mort quasi certaine. Les pics infectieux au niveau des intestins étaient de plus en plus réguliers. En janvier, j'ai décidé de me rendre aux urgences car les douleurs étaient insoutenables. On me prend au bloc opératoire afin de me faire pratiquer une célioscopie et un nettoyage des intestins. Et un premier protocole est mis en place. Voyant que celui-ci ne fonctionnait pas, ma compagne a contacté un médecin américain qui l'a orienté vers l'Allemagne qui avait un protocole qui fonctionnait. Au bout de 2 jours de cure, on a vu des résultats auxquels on ne s'attendait pas. Les lésions commençaient à disparaître. Aujourd'hui, je vais très bien. J'ai repris la vie que j'avais avant. Tout va très très bien. On se rend compte que la famille médicale est une grande famille, que l'aide peut arriver de toutes parts et que ça rassure d'avoir des gens qui travaillent sur cette maladie d'arrache-pied et qui communiquent aussi pour pouvoir aider les patients. Voyant que le premier protocole n'avait pas fonctionné, j'ai commencé un peu à m'effondrer au niveau de l'humeur, de la combativité. Mon état était très compliqué pour moi car je ne pouvais plus marcher. J'étais, cadavérique, avec un teint gris. Je mesure 1,85 m, mon poids de forme est de 72 kg environ, et je me suis retrouvé au plus bas à 54 kg. Et c'est que le deuxième protocole de soins qui m'a vraiment aidé à sortir un peu de la maladie, à être plus combatif, et ça m'a fait vraiment du bien. En passant par une épreuve comme celle-ci, on relativise sur des petits tracas quotidiens. On est content de pouvoir profiter de sa famille, de ses proches, et j'en suis très content aussi. Le rôle de la famille a été déterminant, toujours à positiver. Beaucoup de visites tous les jours de la semaine pour me requinquer, me redynamiser et vraiment pouvoir parler aussi de la maladie librement avec eux m'a fait beaucoup de bien. Aujourd'hui, je me soigne en passant par l'hôpital toutes les 4 semaines pour une cure Et au quotidien, j'ai des cachets à prendre afin de limiter la propagation de la maladie. Donc le traitement me va très bien et fonctionne très bien. Je n'ai aucun effet secondaire. Je suis en rémission. Tout est ouvert pour que je puisse reprendre une vie normale, je puisse reprendre la photo, les voyages et profiter de la famille. Et aussi le travail. Ça serait de former les dermatologues à la maladie de Degos, car ils sont l'avant-garde en fait de la maladie. C'est eux qui vont pouvoir détecter et diagnostiquer la maladie. Et plus les dermatologues seront au courant, plus vite on pourra soigner cette maladie auprès des futurs patients. C'est vrai que la rareté de la maladie fait peur. Dès qu'on parle de maladies auto-immunes, on pense à beaucoup de maladies très graves. Sachez qu'aujourd'hui, on peut en guérir, du moins la stabiliser et très bien vivre à côté de cela.
Okay, thank you very much. It was very nice to have this, this presentation by the patient himself. And so, are there some questions for the concerning the last clinical cases presented by Axel and Marie, and also the clinical cases presented by the members of the foundation? So I have a comment personally. The first is only a comment is to say that the cutaneous lesions are very typical. And I really think that it's not possible to misdiagnose these cutaneous lesions. And sure, it's very important to organize training for the dermatologists, because I am very surprised to see that it's not better recognized by our specialists, our colleagues. And really, when I saw all the differential diagnoses that have been presented by one of the members of the foundation, sorry, I don't remember your name, I really think that it's not possible to misdiagnose with these other diagnoses. And so, Eric, we really have a role to play to organize training and also document. And in our European network and in our the website of Degos disease, and I really want to do that with you, because I am very surprised by such difficulties. Is the first point. The second point is I was a little surprised when I I saw the observation presented by one of the members of the foundation, because it has been mentioned that there was a neurological improvement with baricitinib, and baricitinib is supposed to don't cross the blood-brain barrier, and we know that in children with Aicardi-Goutieres syndrome, we don't have improvement of the neurological involvement, we have improvement of the other manifestations, but not this particular localization of the disease. And so I think that we have really to set up protocols and to be very careful in the interpretation, and to have a best understanding of what are the real progression, the improvement, and so on. And it appears that finally the best treatment perhaps, but I don't know, it's a discussion, the best treatment perhaps at the first line in the severe forms for brain involvement is probably eculizumab on this field of drugs. Probably, I don't know, but it seems to me after this afternoon that is probably the best treatment. And it's possibly not the best treatment for other manifestation. And we have said that a combination will be very important. And in the severe forms, I agree for that. And the most important will be to try to have biological markers to be able to see when we are confronted to a localized forms only with an involvement of the skin, at which moment we have to introduce systemic treatments. And so to put together several clinical cases with the same investigation, same blood samples, and a protocol, an international protocol, will be very important to try to define cluster of patients and to define probably, we can hope so, to have biomarkers for the evolution of the disease. And it's the same for other diseases as cutaneous lupus, cutaneous scleroderma, for instance. It's very important. We know that an evolution to systemic involvement is possible, and so it's very important to have the largest cohort of patients, but with the same assessments and blood assessments to be able to compare, and also to be sure that we describe the same thing. And it's also very important to work on the HPO, as we say, how to characterize the lesions, to be sure to have the deep phenotyping of each manifestation in each organ, to be able to be sure that we have the same patients and with the same disease and with the same type of involvement. And there was a question, and there was an answer also on the chat, but perhaps it's interesting to explain that for all the participants. The question was, why did you discontinue baricitinib first and not anifrolumab in your patient? And so, Emmanuel, you can answer for everyone, perhaps.
Yeah, of course. So, in fact, we decided to stop baricitinib with the aim to remove the stomia. So we decided to stop it because the safety profile and the risk of infection are with baricitinib with anifrolumab, and the fact that the patient told us he described the improvement just a few days after anifrolumab before starting baricitinib, convinced us to stop baricitinib as a first step, continue anifrolumab, look what happened, and finally we monitored, we watched the interferon blood, the blood interferon density, and it remained low. So we think it was the good way.
There was another question for you on the chat. Due to the recent hypothesis that the disease is interferon-driven with the complement system being downstream of it, are you considering stopping the ravulizumab altogether to minimize the immunosuppression?
We have three options. Change nothing because the response is very impressive, and so maybe we have to change nothing. So taper anifrolumab or with the ravulizumab. So yes, I think it could be the next step. I asked myself, I asked to my mentor also. So, but I don't know because there are no other models of interferon-driven vasculopathy with such features of the Degos disease. I mean, strokes, eye involvement, gut of a macroperforation. So, I don't know if it's a good. I don't know. Maybe, but I'm not sure yet.
Yeah.
It's so. Yeah, I don't know.
And you have well explained that there was a decrease, almost complete decrease of the signature interferon with anifrolumab. It's true? You observed?
Yes. With a combination during the first months, but it took, I think, maybe 5 to 6 months to be almost normal, in contrary to what Köhlmeier could we see show with baricitinib. So in our case, it took 5 to 6 months, but in combination, and after the storm gone, we stopped baricitinib, and it remained very, very low, under the normal range or just above, yes. So we induce remission with combination, and I think my feeling is we maintain remission with anifrolumab and ravulizumab. So they have steps.
Yeah, in my experience in children in other interferonopathies as dermatomyositis, and we speak about that just before, anifrolumab is the only drug able to completely decrease the interferon signature. We don't obtain that with JAK inhibitors, for instance, and it's only with anifrolumab that we obtain such result. So just a comment, of course. Are there other comments, other questions? Eric, your hand is, yeah.
Yes, yes, concerning this patient, we discussed yesterday with Emmanuel what we have to do now, because as you have seen, it's really, really nice, has completely removed, and we discuss what we have to do to reduce the dose of anifrolumab or to reduce the dose of ravulizumab, probably not doing both at the same time. Probably first a little decrease anifrolumab dose to 600, but it's quite difficult. It's quite difficult, I think, because as Alex said, it's a chronic disease, and probably the risk of relapse is high. And I had a question one more question. We still have 2 minutes, I think. One more question to Dr. Afridi. I don't know if she already there. Or a comment. It was a comment about the long-term survival of this patient. We have seen that, as you said, Christine, probably eculizumab should be the first-line treatment because some of her patients had long-term survival just treating by eculizumab. So it seems to be possible. But for some other patients, we have to target an interferon pathway to have complete improvement, I think. But with eculizumab could be possible for some patients. It was just question and comment.
For this reason, it will be very important to have a large cohort of patients and to be able to compare cluster of patients and following them since the beginning. It means in the first cutaneous lesions. In your experience, personal experience, as for so rare disease literature experience, did you think that cases without skin manifestation at the beginning, other ophthalmologic manifestations, gut involvement, and so on, are possibly Degos disease but misdiagnosed because the absence of cutaneous lesions, not always occurring during the first days of the evolution of the disease, and perhaps not occurring at all in some patients? I don't know. What do you think? If we compare the description of this other organs involvement and the histology of the gut involvement and so on, what do you think?
That's a question for me because my experience is just based on one case, so it's different. But I see that Dr. Kudosi
for everyone, for everyone.
Yeah, for everyone. Dr. Kudosi, you are there. Maybe you have more experience. What do you think?
Yeah, I just want to comment on things about baricitinib and ruxolitinib. When we wrote the studies, I was reviewing all the data. There are data supporting, baricitinib is able to cross the blood-brain barrier, both baricitinib and ruxo. Now, I think in these cases also, this patient with the CNS involvement, that they do have a kind of increased permeability of the blood-brain barrier because, it's an inflammatory disease. Probably later on, this is hard to pass. I think I will comment with eculizumab based, and Dr. Shapiro has more experience than I do, but I think that eculizumab is a really good medication for gastrointestinal involvement. Once the patient develops other involvement like CNS disease, pericardial disease, pleural disease, eculizumab probably is not enough to control disease. We observe progression of the disease on eculizumab. Then this is what kind of I will comment on this. Then I think for eculizumab, the GI the gastrointestinal involvement can be controlled, but for other systems it's a little bit harder, and we don't know why. Maybe it's just not strong enough or not able to control other diseases, and could be the cause of how these tissues are permeable, if the eculizumab level it's going to the CNS, going to the pericardial, or maybe particular patients do have higher risk and develop this systemic or other organ involvements.
Thank you very much. Thank you very much for your comment. And I have a last question. What is the familial history of all these patients? I mean, genetic tree have been observed have been what is because it's more probably it's more important for the children with a very early beginning of such disease usually observed in adult population. But even in adult population, what are the familial history of the patients?
I think for the NIH, if I can say, you know, there are probably up to 10% of the family history where it's more like we do observe this, you know, brother and sisters or father and kids. But everybody else, we do kind of go very deeply into family history. We have family trees for all these patients. They do have autoimmune disease, but they do not have Degos disease. Then it's not, it's present again, up to 10% of the patient, could be higher in the kids, in patients with early manifestation of Degos disease.
Okay. So, Manfred?
I can just follow up on that question. Our working hypothesis at the moment on that is that, and it was actually mentioned by some of the presenters, that there are probably a two-hit or two-factor involvement in Degos. Once maybe something like a virus that triggers something on a certain genetic background that then leads to the Degos progression. That would explain, sometimes it happens newborns, sometimes it happens in 60-year-old. It comes in kind of waves sometimes. And in many cases, parents or relatives are not affected.
It will be very interesting to try to have a better understanding of this genetic background.
Absolutely.
Patients. Yeah, sure.
And we are running a program, so if you have patients who are interested in, send us your samples.
Okay. So, on the chat, no more questions. So perhaps, Eric, it's time to
conclude.
Yeah, a conclusion. Please. It was really a pleasure to spend this afternoon with all the participants. What do you think, Eric?
I think it was an amazing workshop. Thank you for everybody's presentation were nice, discussion were nice. And what I suggest, what I propose for the future, Christine, and Lee, you are there, I think, the last international workshop was in June 2023. Why not build together the next one? Why not in June 2027 with you? And here the French network with Christina and myself. What do you think?
I completely agree. I think that it will be great. And it will be the opportunity also to try to do training also for everyone and to see where we are, perhaps with some progresses. And now we know each other, and it's possible to contact each other with if we have new cases. It's more rare for me for pediatric population. But it's possible, and sure, Manfred, I observe a new patient with dermatomyositis and pseudo-Degos disease, I will contact you. Sure, be sure of that. And yes, I think that it will be great because in our European registry, in the ERN, the different ERN, we are going to begin to mention such patients to fulfill the registry in your registries and in our registry, and it will be very important to put all these patients together because it's really an overlapping subject with a multidisciplinary approach. Sure of that.
Because Lee or Christine is the lead of the European Rare Skin Disease, the Skin ERN, so it could be a US-EU international meeting.
Yeah.
What do you think, Lee?
I think it's a wonderful idea, and 2 years from now, it might be much easier to get to France than to get into the US. So I like the idea very much.
So not online, but physical, presential?
Yeah.
Face to face?
That would be great. Yeah, I think that would be great.
And coming to Paris?
That sounds delightful.
Okay.
You are welcome. You are welcome.
Deal. We'll build that with you and with Christine.
Yeah, with pleasure.
Okay.
Thank you so much. Wonderful.
Thank you so much. Bye-bye, everyone.
Okay, thank you, everybody, and have a
Thank you.
nice weekend.
Thank you.
Oh, thank you.
Thank you.